Hi, my name is Clarissa Ramkasoon, and I will be presenting case study 2 for the class NU 60604. So patient 2 is a 70-year-old male with a history of congestive heart failure, COPD, and hypertension. He's a 1-pack smoker a day and takes lisinopril, digoxin, and Symbicort daily. He's married to his wife of 30 years and is retired previously as an accountant, and is supported by his adult children and lives with his wife at home. This patient presents with the following symptoms: shortness of breath, chest pain, flank pain, and fever. So the differential diagnoses that I came up with are listed from most prevalent to the least. So starting with acute coronary syndrome, congestive heart failure, and gastroesophageal reflux disease. Acute coronary syndrome is defined by a group of clinical symptoms that are compatible with acute myocardial ischemia. This also includes unstable angina, an NSTEMI, and a dystemi. Symptoms include chest pain or discomfort, which involves tightness, pressure, or fullness. Pain or discomfort in one or both arms, and this includes the jaw, neck, back, or stomach. Shortness of breath, dizziness, lightheadedness, lethargy, nausea, and sweating. So the pathophysiology of acute coronary syndrome begins with atherosclerosis. This is the ongoing process of plaque formation that involves primarily the intima of large and medium-sized arteries. The condition progresses relentlessly throughout a person's lifetime before finally manifesting itself as an acute ischemic event. Coronary risk factors influence this process, and this includes high cholesterol, hypertension, diabetes, and smoking. These factors can damage the endothelium of the blood vessel, which results in endothelial dysfunction, which plays a pivotal role in initiating the atherosclerotic process. A dysfunctional endothelium is characterized by reduced bioavailability of nitric oxide and by excessive production of endothelin-1, which impairs vascular hemostasis and increased expression of adhesion molecules. Once the endothelium has been damaged, inflammatory cells, especially monocytes, migrate to the subendothelium by binding to endothelial adhesion molecules. Once in the subendothelium, they undergo differentiation, becoming macrophages. Macrophages digest oxidized LDL that has also penetrated the arterial wall, transforming into foam cells and causing the formation of fatty streaks. Although the plaque rupture may result in ACS, in fact, 99% of cases, it is clinically silent. So congestive heart failure exacerbation occurs as a consequence of an abnormality in the cardiac structure, function, rhythm, or conduction. Ventricular dysfunction, degenerative valve disease, idiopathic cardiomyopathy, and alcoholic cardiomyopathy are major causes of CHF. It indicates not only an inability for the heart to maintain adequate oxygen delivery, but also it's a systemic response attempting to compensate for the inadequacy. The determinants of cardiac output include heart rate and stroke volume. So the heart is viewed as a dynamic pump. It's not only dependent on its inherent properties, but also what is pumped in and what it must pump against. CHF is a common occurrence when contractility of the ventricle is reduced, which leads to a decrease in stroke volume. When the left ventricle does not pump its blood into the systemic circulation, the normal volume of blood returning from the lung cannot enter the left side of the heart. This leads to congestion in the pulmonary circulation, which increases capillary pressure and possible pulmonary edema. Fluid is forced into the alveoli, and this process is known as left-sided congestive heart failure. With right-sided CHF, the right ventricle cannot maintain its output, so less blood proceeds to the left side of the heart in the systemic circulation. This is shown by increased blood volume and congestion in the legs, feet, and eventually in the portal circulation and neck veins. So I found this picture, which is a great representation of the differences between left and right-sided heart failure. Gastroesophageal reflux disease, also known as GERD, compromises a wide spectrum of disorders ranging from the presence of typical symptoms alone through to more severe complications, including erosive esophagitis, Barrett's esophagus, and esophageal carcinoma. Impaired esophageal clearance is responsible for prolonged acid exposure of the mucosa. The pathogenesis of gastroesophageal reflux disease is multifactorial, involving the transient lower esophageal sphincter relaxations and other lower esophageal sphincter pressure abnormalities. As a result, reflux of acid, bile, pepsin, and pancreatic enzyme occurs, which leads to esophageal mucosal injury. In this slide, I will explain more of the pathophysiology of GERD. So GERD involves the periodic flow of gastric contents into the esophagus. The severity is closely associated with the competence of the lower esophageal sphincter or the relative pressures on either side of the lower esophageal sphincter. A decrease in the LES pressure or an increase in intra-abdominal pressure allows for more of the gastric contents to reflux back up into the esophagus. Delayed gastric emptying plays a major role in this. So I found a nice picture that shows the difference between a healthy and GERD. So the week 7 differential diagnosis versus the week 10 differs because in week 7 I decided to focus more on respiratory conditions. But then through doing research and looking more into this case study, I determined that this may be more related to his cardiovascular system, so I decided to choose ACS, CHF, and GERD because all of these have similar presenting symptoms. Diagnostic tests include an electrocardiogram, blood tests, so the 3 major cardiac blood tests that they do is a C-reactive protein, troponins, and CKMB. And then I would also do CBC, BMP, and a lactic acid. Chest x-ray to check for fluid overload, a stress test, and then if the stress test is positive, a cardiac catheterization to see if there's any blockages. So there are 2 types of cardiac catheterizations. There's a left-sided and a right-sided one. With the left-sided one, it looks at if there are any blockages in the coronary arteries. And with the right-sided cardiac cath, it focuses more on fluid overload, and it determines if the patient is in fluid overload. For my treatment plan, I would have this patient admitted to a cardiac telemetry unit where he can receive continuous monitoring. His oxygen status will also be closely monitored. This patient would be monitored for at least 48 hours. He would receive opioid analgesia such as morphine or a vasodilator such as nitroglycerin as needed for chest pain control. Routine labs such as troponin, CKMB, and C-reactive protein will be monitored. And then the patient can go to the cardiac catheterization to reveal if he does in fact have any blockages in his heart or if he's in fluid overload. This patient will follow up with a cardiologist and his primary care physician 1 week after his discharge. With his cardiologist, he can go over any new meds that he needs to be started on and go over if he's experiencing any symptoms. And for his primary care physician, they should always be involved in the patient's care and keep updated with what any admissions or if there are any issues with the patient. Lastly, this is just my reference sheet and it's placed in APA formatting. Thank you for listening to my presentation.